I hope my slides are visible.
Yes, sir.
So, as we are well aware, time tested, this drug is the trastuzumab, which has been used in this HER2 positive breast cancer. And it will be, this talk will be, this webinar will be incomplete if we don't talk about it. So, as we are well aware that HER2 disease is in itself an aggressive subtype, and most of the time we have seen they relapse early, and moreover they have got a visceral involvement, and predominantly we get to see more of a brain mets. And then if we don't treat them with the anti-HER2 agents, yes, they have got a very short DFS and overall survival. So moving on to the next slide, as you can see that if we see this data is from the MD Anderson Cancer Center, and what they have seen that over a period of around this uh, 12 years, what they have seen that those patients who are not treated by anti-HER2 agents, they have categorically shown that the disease-free survival was definitely inferior in comparison to those who had HER2 negative. So even if we club all the breast cancer subtypes that like luminal A, B, or basal or HER2 among it, if we don't treat them with the anti-HER2 agents, the prognosis is the worst. So starting with the general case, as we have a patient that who has a 61-year-old patient who has underwent upfront lumpectomy, and besides that, sentinel lymph node pathology showed invasive cancer. It was T2 and 0 and 0. And ER HER2 was triple positive, and HER2 was found to be 3 plus by IHC. So if we look at the NCCN guidelines, what they say that yes, those tumors who are of more than 1 centimeter, we are supposed to treat them with just chemotherapy and trastuzumab, and along with that, endocrine therapy. So the evidence for that is we have a multiple trials in the form of like HERA, NCCTG, or BCIRG everywhere. As you can see, the disease-free survival benefit has been shown to be somewhere around 6 to 12% with the addition of a trastuzumab, and moreover, that has also translated in terms of a overall survival also. So, what are the risk factors for recurrence of those early breast cancers, those who have been treated with trastuzumab alone? And after doing this univariable, multivariable this analysis, what they have found that it was primarily T stage, and then besides that, the nodal positivity, and then the third important point was the hormone receptor status. So, adjuvant therapy, patient with lower risk HER2 positive early breast cancer, yes, we are supposed to treat them with this chemotherapy plus trastuzumab, and the evidence for that is earliest trial was that of APT trial, in which they took all those patients who had a early disease. Early disease means those who had a less than 3 centimeter disease and they had a node negative disease. So they treated them with this chemotherapy or chemotherapy plus trastuzumab, and trastuzumab was completed up to complete 1 year. So as you can see, the disease-free survival, it was quite good. 3 year DFS was around 98.5%, and then if we 7 year DFS, it was somewhere around 93.3%. But then if we just them stratify with hormone receptor positive versus negative, as you can see, the hormone receptor positive did slightly better. Now, there was an attempt to improve beyond trastuzumab in an adjuvant setting in all those early HER2 positive breast cancer patients. As you can see, they tried to just introduce chemotherapy altogether, chemotherapy free regimen. That was by the introduction of a TDM1, and another arm continued with the conventional paclitaxel plus trastuzumab. So follow-up was after 5 years of final dose of TDM1 or trastuzumab paclitaxel. So as you can see, in the APT and attempt arm, in both of the arms, as you can see, paclitaxel trastuzumab produced 3 year DFS of around more than 90%. It was 92% in this attempt arm and 98.5% in the APT arm. But with this introduction of this trastuzumab, this amtensin TDM1, this also led to the 3 year DFS was somewhere around 97 or 98%. But then most important point was regarding the safety. So overall, if we see the here the toxicity wise, TDM was definitely, this worse in comparison to the trastuzumab paclitaxel, and moreover, attempt it didn't meet primary endpoint of a 40% relative reduction in toxicity with TDM1. So this was all about the early HER2 positive breast cancer. What about those who have got a higher risk HER2 positive early breast cancer? So again, the patient who has been upfront operated, that 44-year-old and who has undergone bilateral mastectomy with axillary node dissection, and tumor was found to be a 5.4 centimeter. 6 out of 11 nodes were found to be positive, and again she was having a triple positive disease. So here, the noteworthy point here is that as per the NCCN guidelines, as you can see here, they have mentioned clearly as a category one recommendation for those who have got a node positive disease and those who have been operated upfront, that here the trastuzumab is pertuzumab is to be added to the existing trastuzumab and endocrine therapy regimen. So for that, we have evidence already in the form of a affinity trial, I mean, which has clearly shown, and now we have a very mature data for this 10-year. And here, as you can see, that invasive disease-free survival was definitely better with the addition of a pertuzumab, but this was applicable to those patients who have got a node-positive disease, not to those who have got a node-negative disease. So this is really very important in our scenario because we don't every time we don't get to see a HER2 positive patient who has been seen by a medical oncologist and who will treat her with a neoadjuvant chemo. There are patients who are upfront operated in spite of having HER2 positive, node positive disease by general surgeon. So I mean here we can use those guidelines or those recommendations to treat that patient. Now, what about improving beyond this? I mean, giving this trastuzumab, pertuzumab. What about extended adjuvant therapy? So again, we can take a background of a similar patient that okay, that patient was treated with adjuvant chemo, trastuzumab, pertuzumab, and endocrine therapy. Here we have a NCCN guidelines which they have mentioned that yes, beyond this pertuzumab, trastuzumab, hormone therapy, you can even consider using adjuvant neratinib. So, I mean, this adjuvant usage of a neratinib has been particularly proven to be of benefit in those who have a hormone positive, hormone receptor positive, HER2 positive disease. But then, one thing that has to be noted down is that the benefit or toxicities associated with extended neratinib in patients who have received pertuzumab is unknown. But biggest problem with the usage of a naratinib is the diarrhea. I mean, the antidiarrheal prophylaxis is to be almost started in almost more than 50% of the patients. So with this, I mean, that drug has really taken a back seat, and majority of the, I mean, physicians have felt a bit of a reluctance in using that. So this is the data for that XTNet 5-year update, neratinib versus placebo after adjuvant trastuzumab in HER2 positive early breast cancer. So primary endpoint they took was invasive disease-free survival at 2 years. So as you can see, there's a difference of around 3% invasive disease-free survival. But then when we see it in doing risk this stratification in terms of a hormone receptor positivity, was more beneficial in hormone receptor positive disease. That is, there was an improvement of around 4%, while in hormone receptor negative disease, it didn't made any big difference. So, moreover, if we see the hormone receptor positive and less than 1 year from the last dose of trastuzumab, again, the difference was 5%. But if this hormone receptor positivity and less than 1 year from the last dose of trastuzumab without PAC-CR after neoadjuvant treatment, the benefit was a bit more pronounced. That is 7.4%. So we can say with confidence that yes, somebody who has a this triple positive disease and node positive disease, and he or she has been treated with this pertuzumab, trastuzumab. Yes, we can improve beyond it with the addition of a this neratinib. Now, coming on to the neoadjuvant therapy, as already has been said about it by Dr. Burhan. So here we can take a patient who was a 33-year-old, and here again she had a triple positive disease, and uh, so now the question arises: who are the patients who are supposed to receive this neoadjuvant chemo? So neoadjuvant chemo are any patient who has got a tumor of a more than 2 centimeter, or any patient who has got a node positive disease. So regardless of the hormone receptor status, should receive neoadjuvant chemo with a this trastuzumab, pertuzumab with chemotherapy. So for that, we have this evidence, and that has been already said by Dr. Burhan, like Neosphere study and Trifina study. Now, as I already put the question to Dr. Burhan, that I mean, where does he places the usage of anthracycline in the era of this dual anti-HER2 in a neoadjuvant setting? So here we have evidence for that in the form of a phase 3 train 2 study. As you can see, they here try to give this just TCHP, or another arm they gave FVC also. And then what they observed, that the primary endpoint they took was pathological complete response. I mean, pathological complete response was almost similar in both of the arms, and moreover, it was consistent across all the pre-specified subgroups, whether you talk about the T stage or a nodal positivity or a hormone receptor positivity or age. So, moreover, there was no statistically significant difference in event-free survival with or without anthracyclines. So, what about post neoadjuvant therapy? So, again, as I mean, already has been said by this Dr. Burhan, that somebody who has been exposed to this pertuzumab, docetaxel, trastuzumab in neoadjuvant setting, and after that, residual disease is present. Yes, we are supposed to use TDM1 alone for 14 cycles, because for that we have evidence in the form of a Catherine study. So we can say clearly for the time being that guidelines are quite clear. If patient has got a very early disease, that is T1A or B, you can subject the patient straight away to surgery and give in adjuvant setting this paclitaxel, trastuzumab only, and complete trastuzumab for complete 1 year. But beyond it, I mean T1C, if patient has got a this high risk, they took all those patients who have got an age of less than 3 years, or a grade 3, or a hormone receptor negative, or a multifocal disease. So they are supposed to receive neoadjuvant. Otherwise, you can also take the patient for upfront surgery. But beyond it, the guidelines are quite clear. Yes, take for a neoadjuvant chemo, and then see for a residual disease. If present, go for TDM1. If paths here, you can carry on with the this pertuzumab, trastuzumab. Now, overall, if we sum up the whole of the early breast cancer, I mean, HER2 positive disease, trials have been carried out to escalate as well as de-escalate. I mean, escalation was in the form of, yes, no PCR, go for a TDM1. Besides that, even bevacizumab has been tried, which has been found to be a negative trial, and then neratinib, it has been found to be positive trial, but yes, at the cost of a toxicity. And then, other than that, positive trial was in the form of affinity. And then, moreover, even trastuzumab dilution has also been attempted to be of 2 years. That was a HERA study, but again, it was a negative trial. And then, other than that, de-escalation was attempted in the form of, like, I mean, anthracycline-free regimen, and that has been proven to be equally beneficial. And then, other than that, even chemotherapy-free regimen has also been tried, like ATEM, that was a negative trial. Moreover, important point was even reducing the duration of adjuvant trastuzumab has also been tried, and it's not one or two. I mean, there are five trials. But if we see out of five, I mean, four trials have got results, and out of those four, only one has supported, which has been proven to be of non-inferior for the usage of a 6 months. But otherwise, the rest of the three, they have been considered as a negative trial only. So besides that, I mean, this was all regarding the early breast cancer in this. And Now, what about the trastuzumab in a metastatic HER2 positive? Yes, we have early trials like HO 648G or M77001 or tandem study. As you can see, they try to stratify those patients who have previously received anthracyclines, yes, or anthracycline exposed or not, and what they gave and this in chemotherapy arm, like adriamycin cyclophosphamide or paclitaxel. So what they have shown that clearly, yes, it has been proven to be to work in even in a metastatic setting after the addition of to chemotherapy, and we are well aware. I mean, we are to see in daily our practice, and even complete responses have also been seen. So similar was the case with overall survival. Now, coming on to cardiotoxicity, as expected, I mean, addition of a trastuzumab to anthracycline regimen has been found to be associated with a high cardiac toxicity. Now, then besides that, other than that, we have another M7001 study. Again, here they gave only docetaxel, and another arm they gave docetaxel plus trastuzumab. Again, as you can see clearly, addition of a trastuzumab has remarkably benefited the patients. Now, other than that, there was another study, tandem study. Tandem study was mainly carried with an intention, as we know that there is evidence of a crosstalk between the HER2 and the estrogen receptor signaling pathway. So study was taken particularly those who have got a triple positive metastatic breast cancer. So what they have shown that in one of the arm they just gave anastrozole, another arm they gave anastrozole plus trastuzumab. So see, this regimen can be of a good use in particularly in all those elderly patients. So as you can see, with the addition of a trastuzumab to anastrozole, there was almost a doubling of a median PFS. And similar was the case with the OS, although not that pronounced in terms of a, PFS, but yes, there was a difference. It was around 5 months over this anastrozole alone. And then, moreover, clinical benefit was found to be in almost all of the patients. Then yes, there was a safety profile. I mean, there were cardiac side effects more in the trastuzumab arm. So we can say that yes, in any metastatic HER2 positive breast cancer, trastuzumab holds a cornerstone. And in presently, as already has been said about that, yes, we are supposed to combine trastuzumab with the pertuzumab in upfront setting, and then beyond it, we have multiple options. So with this, I conclude my talk. Thank you. So